And so in the Ragon Institute, our overarching vision is to harness the human immune system and prevent and cure human disease. Kind of a very large kind of endeavor to tackle, but that we've made great strides on. And so, of course, to kind of continue on talking about immunity to COVID-19, I do want to just give a very brief overview of what the human immune system is and what it does. And so the human immune system, classically, we separate into kind of two arms. So we have the innate immune system and the adaptive immune system. And just to explain what that means, from the innate immune system side, here it's kind of this mix of components that include cells that are in your blood and in your organs, that include like neutrophils, macrophages, natural killer cells, as well as soluble proteins and substances that you produce all over the body that help protect you from infections, bacteria, viruses, worms. And so kind of the analogy to these is, imagine the first responders, kind of the EMS, the firefighters that come in to like a crime scene where something bad has happened, and they just kind of try to assess the situation and try to do damage control. However, that alone is usually not sufficient to completely fight off a pathogen, which is why we have the adaptive immune system to fight off all the bad bugs in a more long-lasting fashion. And it's also divided into kind of cells and soluble proteins. And so on the cellular side, we have T cells as the main cells that mediate a cellular response from the adaptive immune system. And they usually come in two flavors. We have these helper CD4s that kind of coordinate responses, and we have the killer CD8s that actually kill cells that have been infected with a virus or a bacteria. And on the humoral side, we have B cells, which really their main function is to produce antibodies. And so many are familiar with what antibodies are, but just as an analogy, again, so on the adaptive immune side, you have all the kind of specialized detectives. There's this whole process of selecting who's the good guys, who's the bad guys, and then kind of forming this elite squad team that goes in and very precisely targets and eliminates pathogen. And on the T cell side, it's kind of like the hand-to-hand combat on the ground. And from the B cell side, they're kind of off producing antibodies like missiles to kind of hit the enemy from afar and prevent it from ever really invading. So that's kind of like the general concept of the human immune system, but kind of how do we adapt this to what we know from COVID? So immunity to COVID, really you're trying to achieve two things. You're trying to neutralize the virus and eliminate it if you're infected. And so this is a schematic of SARS-CoV-2, the cause of COVID-19. And I just highlight here this protein on the surface of the virus called spike, that it's essential for the virus to actually stick to human cells and infect them. And so the role of antibodies in someone who has antibodies against COVID is to do the following. So if the virus comes in and there are receptors expressed on cells, for example, in the respiratory tract, in your nose, in the lungs, this virus will normally attach to those cells through that receptor and infect them. But if you have antibodies in the way that neutralize the virus by binding to it and blocking it, the infection doesn't happen. So antibodies ultimately prevent viral infection, entry and infection. On the other side, however, there's the role of T cells. Now, T cells don't directly target the virus, but what they do is that in the case of a virus actually coming in and infecting, here the cells in red are the ones that are infected, those cells become these virus factories. That's kind of the life mission of a virus, to make copies of itself. And so what T cells do is that they recognize cells that have been infected and they kill them, they eliminate them. That way you don't have any more virus production from the cells that were infected. And so T cells' role is to stop virus production and replication. Again, with those analogies, T cells are kind of the hand-to-hand combat on the ground, kind of attacking the enemy that's infected a cell, and antibodies are kind of from afar trying to stop the enemy from entering in the first place. And so we know that these kinds of immunity are elicited by the actual viral infection. But of course, that's a risky game. You don't want to get infected with COVID because there's many other risks that you're taking just to develop that immunity. But what we do know is that vaccines elicit this kind of immunity, which is good because they come at little to no risk at all. And so that's what we're going to be talking about today. I do want to mention, though, that with this great immune system that we have, viruses do try to escape, and this is why we're having this emergence of these new variants that try to escape this immunity, so the virus can keep replicating itself and spreading while we're trying to fight it off. And so my work comes in from the antibody side, and a subsequent presentation by Gaurav on T-cell immunity will follow. So on the antibody side, just to mention again, we're able to detect these antibodies that neutralize the virus and variants of the virus by using this platform that we developed at the Ragon Institute. And it's a platform where we actually make these fake kind of dead viruses, and we test whether they're able to infect cell lines in the presence of serum from people that have been vaccinated or not. And so in kind of a very high level view, we ultimately spit out results of like, what is the level of neutralizing antibodies that an individual has in response to vaccination or infection or both, etc. So talking about all these variants, which is kind of the main point of this talk, I do just want to highlight kind of the history of how these variants have emerged. So we know COVID-19 kind of started in Wuhan with an original Wuhan strain, December 2019. And here I have this kind of tree. It's a bit complicated, but just imagine on the y-axis. So here on the vertical axis, it's timeline. So here on top is February 2020, and at the bottom here is December 2021. And so what you're seeing here is each dot is a sequence of the virus that has been deposited on this online database called GISAID, which is amazing. It's this worldwide effort for people to have this genomic surveillance of all the viruses and the variants that have been emerging. As you can see in the beginning, we had the original strain from Wuhan with probably a single mutation that arose, and suddenly came out all these other variants. So for example, here in yellow, these dots correspond to alpha variants that came out in different locations. And as you can see, they're coming out at the beginning of last year, February, March, April, which we know was a time of kind of the alpha wave. And then here we have in green, towards the end of the summer last year, July, August, September 2021, these Delta variants, and that came out and took over the world. And just here, and this diagram is a bit out of date, at the end of 2021, we have these emerging new variants that we called Omicron. And the more updated data from the CDC shows that Omicron, as of maybe 2 weeks ago, has become by far the dominant variant. Like 99% of circulating strains are Omicron in the United States. As you can see here, it overtook Delta completely. And so what are the differences between Omicron, Delta, and the original variant, the original virus that came out from Wuhan? So here I have a schematic of what these differences are. I'm focusing on spike protein, which I said is the important protein on the surface of the virus that is targeted by antibodies to neutralize it and block it. And so if you look at the wild type protein sequence, here I'm just indicating kind of the different regions of that spike. If you compare it to Delta, you can see in Delta, you have all these mutations. And here I'm highlighting the 9 main mutations that arose in Delta. And this alone was worrisome that spike was mutating. And if you look at these crystal structures, so these very special images of what the protein looks like at a very tiny microscopic level, you can see that these mutations, which I'm coloring in heavy reds and blues, are concentrating kind of at the top area of the spike, which is usually where the antibodies are binding. Now, if you compare Delta to Omicron, Omicron just had this kind of scatter of mutations, a lot of them concentrating around this region in red, which is the main target of antibodies that neutralize the virus. And so you can see here at the bottom right, here's a little image of what that spike protein looks like. And there's tons of mutations that you can imagine are mediating escape from the immunity we're trying to elicit by vaccines, keeping in mind that vaccines, Moderna, Pfizer, Johnson, those are based on the original wild type spike sequence. And so, so keeping in mind kind of these differences among the variants, we wanted to test, well, what's going on with people's immunity to these variants in all the different patient cohorts that exist in the United States. And so through a great concerted effort with MGH and Ragon and many individuals, we were able to amass a cohort of patients that had either received Moderna, Pfizer, or Johnson, and had either only received their primary series of vaccinations way in the beginning of 2021, received it much more recently at the time to which we were collecting it, so they were kind of freshly vaccinated. We also had people who had been vaccinated, but also had a history of prior infection. And then we had people who had recently gotten their booster vaccine. So the study was done in December, And we had many individuals who among the months of October and November were getting booster shots. And so among these different cohorts and the different vaccine manufacturers, we asked ourselves, okay, how are these individuals faring off against the variants? So this is what we found. We found that the third dose, a booster dose of an mRNA-based vaccine, is really critical to inducing good immunity against SARS-CoV-2 and its variants. And so here I'm showing you the ability of people's blood to neutralize the original wild type virus. So here in red are individuals who got two shots or 3 shots of Moderna. And here in percent, I'm putting what percentage of people do we detect this kind of immunity, neutralizing immunity, and all of them do. And they have very high levels, as you can see here on the y-axis. If you look at people who got 2 versus 3 shots of Pfizer, they also had very high levels of neutralization of the virus, and all of them had the response. If you look at Johnson, and this has been described by many others, Johnson was inferior in inducing these neutralizing antibodies. There were a few individuals that could make them, but not everyone. However, if people who got Johnson had a booster shot with Moderna, now everyone had neutralization against the original virus, and at pretty good levels. Now, if you look at how that compares to neutralization of Delta, which used to be the dominant strain in the United States and the world, you can see that these vaccines fare off pretty well towards Delta, having even 2 shots of Moderna. At least in our cohort, 100% of people have a detectable response. It is lower, you see some dots dropping off. Pfizer was a little less potent at inducing these neutralizing antibodies against Delta, and Johnson was inferior to Moderna and Pfizer. But again, when you had a Moderna booster, you regained the ability to neutralize Delta, and 3 shots of Moderna and 3 shots of Pfizer were also amazing at generating neutralizing immunity against Delta. Now, Omicron, which is the current virus, looks like this. And this we thought was fascinating because it kind of surprised us from our understanding of normally how we would think an immune response would develop when you're giving the same dose, the same vaccine just several times. So what we're seeing here is that for Omicron, if you only had 2 doses of Moderna, only a few people will develop neutralizing antibodies. So here, 32% of our cohort was able to make antibodies against Omicron that neutralize it. In our case with Pfizer, 0% of our individuals that got 2 doses of Pfizer were able to make antibodies that we could detect. Again, in larger cohorts, if we included more people, we might have caught a few that did have some antibodies. But as you can see, 2 doses of Moderna or Pfizer were not enough to induce antibodies at a sufficient level to neutralize Omicron. However, if you have 3 doses, the story completely changes. Almost everyone now has the ability to neutralize Omicron, and it's most everyone. You're 97% for Moderna triple shot or Pfizer triple shot. In the case of Johnson, and again, it's a small cohort, but we did see that of the individuals that we tested, it was 8, 7 of them had good neutralization against Omicron. It was lower level than Pfizer or Moderna, but still detectable. So really kind of telling us, and it was a very timely thing we found in December, that booster shots are very critical for inducing immunity against Omicron. So that has been kind of the big push to get people to have boosters, especially before the holidays happened. So I just want to show you that our results that we see in kind of in vitro, which is like in plastic dishes, it's all like in test tubes, is reflected in real world data that has been acquired since then. This is quite old, there's a lot better data, and I know we have data more local, but there was a study from the UK that showed that yes, if you have 3 doses of Pfizer here, or 3 doses of Moderna, then you can see now here, or 2 doses of Pfizer with a booster of Moderna, you see here that the ability for the vaccine to prevent infection, to prevent significant disease with COVID-19 is a lot higher than if you hadn't been boosted. So definitely boosters provide efficacy against Omicron in the real world. And we've seen this now just many, many times. Now, just to talk a little bit about Omicron and kind of why it was so different. These graphs are a bit complicated, but just the general point is we found that in vitro in plastic dishes, Omicron seemed to infect cell lines more readily than the other variants. So in our culture system, we found that Omicron was 4 times more infectious than wild type, and 2 times more infectious than Delta. And so this kind of was already a kind of a finding of, oh, this is probably why Omicron took over. It just infects cells better. And that was kind of all we had found. But other people, since this was a worldwide kind of effort of everyone trying to study Omicron, had found that actually Omicron replicates much more quickly in the upper respiratory tract. So you can imagine it just is more readily infects, and probably why it's so contagious. However, on the other side, in the lungs, it seems to replicate less efficiently than the original virus, which may explain why we're seeing less disease severity with Omicron. And some people had dove into the mechanism showing that Omicron enters into cells in a different way than the original wild type strain, because it loses some requirements that the original virus had, in this case, using this serine protease temperase 2 for entry. It doesn't need it anymore. Now, that's kind of my portion of the talk. Now I will pass it off to Gaurav Gaiha, who's going to talk about T cells. And I do want to mention T cells are, I think, the really important players of the story of immunity against COVID, because these are the cells that actually eliminate a viral infection and will save you when you become infected with a virus. You cannot live through a viral infection without T cells. You actually can live through a viral infection without antibodies. You won't be protected in the future, but T cells are really what kind of make you overcome COVID and survive it. And so excited to see what he's going to present. But just before then, I just want to give acknowledgements to everyone who's collaborated with me here in the Ragon, at Mass General, people from abroad, from Germany, and everyone who donated blood in a very last minute fashion. And I'm happy to take questions at the end of our talks.
Well, thanks, Wilfredo. That was a terrific talk you just gave, and I also appreciate the setup you provided for T cells as well. And I just want to thank everyone for organizing this event and for the invitation to speak today about T cell responses to SARS-CoV-2, and then more specifically to the Omicron variant, which has really been an interest of mine for many years. So just by way of introduction, as mentioned, I grew up in Chicago, and then I headed to the UK to pursue my doctoral studies in biochemistry and immunology. And then in 2007, I kind of made Boston my second home, first by doing my MD in the HST program, similar to Wilfredo, and then pursuing my kind of clinical training at MGH, and then doing my research fellowship at the Ragon Institute, and then starting my lab about 1.5 years ago. And I think, Wilfredo gave a wonderful overview of the immune system. My specific area of interest has definitely been on the T cells. So these helper CD4 T cells, which help coordinate kind of the immune response, and then these killer CD8 T cells, which really help with kind of viral clearance and detecting virally infected cells and eliminating them. So for many years, I did work on HIV, and really over the past 2 years, it's been taking a lot of the lessons we've learned from HIV and applying them to SARS-CoV-2 and seeing how we can basically learn more about the immune response and potentially also develop new interventions leveraging T cells to fight this disease, which I'll touch on at the very end of my remarks. So I think Wilfredo spoke very nicely about antibodies to SARS-CoV-2. A primary function is to bind the virus and really neutralize and prevent infection from taking place. But what I think we've seen, over the past 2 years, while the vaccines have been this amazing development in terms of being able to induce antibodies in large numbers of people, both locally and globally, we're starting to see some issues with the antibodies with waning titers have kind of increased susceptibility, particularly to some of these variants. And then we're also now seeing with particularly Omicron evidence of variant escape. And I think in part that's just due to the fact that the antibodies really are detected at just one part of the virus, which is the spike protein. And so there is this other side to the immune response to SARS-CoV-2, which is really also very important, and that's the T cell side. So if the virus is able to get past the antibodies and actually infect a cell, what ends up happening is the virus will use the cell to generate new viral proteins, to then generate new viral particles. But small parts of these proteins will actually be kind of chopped up into little pieces and will actually serve as beacons in complex with these other surface molecules on the cell as a kind of a signpost to the immune system, to T cells, to tell them, I'm a virally infected cell. You should recognize me as something foreign and dangerous and eliminate me. And that's exactly what happens. The signpost gets recognized by these cytotoxic killer T cells. They come along, they recognize, and in a very specific way, they're able to kill this virally infected cell and eliminate it from the body, and therefore be able to control the infection. And I think additionally, what we found is that these T cells are highly durable. They don't wane in the same way that antibodies do. And they're also been associated with more mild disease in kind of patient cohorts that we've studied. Up to this point, up to studying Delta, we've also seen that they have had a very strong preserved response to the variants. And I'm going to tell you about some of the work we've recently done with respect to T cell responses to Omicron. And part of that is that, really the advantage that T cells have over antibodies is that they can target the spike protein, which they do when people are vaccinated, but they can also target non-spike proteins. And this plays into people who've had prior infection and also to some new approaches that we're taking to develop some second generation vaccines. So this was just a study that we did recently to look at T cell responses to the Omicron variant. We had some very straightforward questions. So the first was, do the mutations in the Omicron spike protein, for example, affect the T cell response and recognition that's induced by prior infection or vaccination? And then the second question we had was, how do the booster doses affect the T cell response to Omicron? Is there also an additional benefit to booster vaccination beyond the antibodies that we can see in the T cell response? So I'm going to focus on this first question first. We were also able to leverage a cohort from Chelsea, Massachusetts, which gave us a group of people with a wide variety of demographics. So we were able to look at 76 volunteers, predominantly a female group of individuals. And these were people who had just vaccination or had booster doses. Some had prior infection, but no vaccination. Some had prior infection and vaccination, and some had prior infection and then even a booster dose. So basically a wide variety of people for us to be able to look at. And we were able to get them at different time points. For people after vaccination, it was about 6 months. And then for people after booster doses, it was as soon as 8 days to up to about 2 months after that booster dose. So be able to give us a good cross-sectional look at how T cell responses in the community would be reactive towards the Omicron variant. The way that we did that, I'm going to show you some of the raw data that we actually generate in the lab for you to look at. We use something known as an ELISpot assay, which is supposed to look at effector T cell responses. We literally see spots within our culture dish that tell us if a T cell is reacting to the Omicron variant or to the initial wild type SARS-CoV-2. And then we also use another assay known as a proliferation assay, which looks a little bit more at the memory T cell response. And that requires us to use a machine called a flow cytometer, but we can detect the fluorescence of these cells. And that tells us if there's a T cell response present in the blood of these individuals. And this is some of the things that we're just doing at the Ragon Institute. So here's just an example of some of the data. So this is an individual who had no prior infection and was not vaccinated. And so we don't see any spots as we expect because they've had no exposure to either SARS-CoV-2, to the wild type, or to Omicron. But now here we can start to see individuals with either prior infection, vaccination, or people who had prior infection and vaccination. And you can see these spots emerging from their blood, which is indicating reactive T cells in their blood to, in this case, either the wild type spike, as you can see here, the Delta spike here, or the Omicron spike. And what we're seeing really nicely in these people is a complete preservation of these T cell responses. This is really reassuring. It's showing that the T cells that were either induced by prior infection or vaccination to the initial wild type vaccine or wild type infection are still remaining equally reactive to Omicron. This was really reassuring. But we saw some people who didn't quite have that response. I think it's important to just share that kind of information and data with the community, where we did see people who actually had a loss in their T cell response to Omicron. So that was either in prior infection or vaccination, or people had that combination of both. So similarly to what Wilfredo was seeing with the antibodies, there was a subset of individuals who had a reduction in their T cell response to the Omicron spike protein as a consequence of those mutations that kind of developed in that variant. And so here's just a look at summary data of all the patients that we looked at. The ones in red indicate those who had a real significant drop off in their T cell response. And so what we found was about 21% of the people in our cohort didn't have as robust that kind of T cell response, that backstop to the Omicron virus. And that was really in contrast to, say, Delta, where only 9% of individuals were really affected. So this did suggest that there was really a shift. The virus was in some way escaping not only from the antibody response, but to a degree also from the T cell response. We did this other assay that I mentioned, this proliferation assay. This is just describing how it's done. And really what we looked at using that flow cytometer that I mentioned is the presence of these cells on the flow cytometer. And so what we found, is that we can look at those helper CD4 responses and those killer CD8 responses. The helper CD4 responses seem to be, again, largely preserved, which was great. The kind of coordination of the immune response was largely intact. We only saw a few individuals who actually had a significant decrease as a result of the mutations in Omicron, as indicated by these kind of red lines. But we did see that in the CD8 T cell response, those killer T cells, we saw more significant drop off. So you can see here, this individual had about a 4-fold drop off in their CD8 T cell response. And here we see an individual with about a 3-fold drop off in their T cell response. So it was definitely much more significant in these killer T cells, the effects of these mutations from the Omicron variant. So just important that we were able to highlight that and address. So the question was, how did the booster doses do in terms of trying to rectify some of these things that we're seeing in either individuals who were vaccinated or had a prior infection and vaccination? So what we looked at was in 25 people, we were able to get pre and post boost specimens. So we got them before and then about 10 days after their booster vaccine dose. And as you can see, this is an individual pre-boost, and here are the kind of T cell response is quite low, but post-boost, we had this incredible increase in the magnitude of the T cell response. And here's just 2 representative examples. What we found is that booster vaccines increased the T cell response to either the wild type virus or to Omicron by about 20 times. So just indicating further reason why booster vaccination was so important during the time of this new variant. We did, in fact, also find some people who still had that drop off in their T cell response when you compare their reactivity to Omicron than to the wild type, for example, but the magnitude was much higher. So you can see here, we again had about 9% of people that we looked at still have that reduction in their T cell response. So the magnitude was so high that we're not sure actually if this is actually clinically significant. We think that the booster vaccine dose is still, for these people, still giving this very high T cell response that could potentially induce kind of a more mild disease outcome if they were to get infected. So again, emphasizing the importance of booster vaccination. So just as a summary, critically, the T cells beyond the antibodies provide an additional immune backstop against severe disease from SARS-CoV-2. They're really kind of an essential component to really making this more of a mild disease than severe in a lot of people. We did find that the responses from individuals with prior infection and vaccination remain largely preserved against the Omicron variant, and that's good news. But we did see this subset of about 20% that did seem to be affected. But importantly, booster vaccine doses really greatly enhanced the T cell responses to the wild type and the Omicron variant. I think it further emphasizes the importance of those booster doses, particularly as these new variants are emerging. I just want to share one last thing. My lab has really been focused on working towards a broadly protective T cell vaccine to augment these antibody approaches. Work that was led by a very talented PhD student and another physician at the Mass Eye. We were able to devise a T cell vaccine that's really resistant to either the variants and could potentially be used as a pan-coronavirus vaccine. And this is really work that's in development. And so we're trying to generate this T cell vaccine. So in addition to the spike, we'd be able to induce both antibody and robust T cell protection. So that's hopefully something we'll be able to further contribute to the pandemic. So I'm just left with some acknowledgements to members of my lab, notably Anusha Nathan, and then also to Vivek Narambai, who greatly assisted with leading the study on the Omicron variant, and then to Bruce Walker and to all of the patients who participate in our study. So thank you very much for your attention. With that, I'm going to hand it over to Derrick Neal, who's the public health officer from Cambridge, who's going to share some additional information about the current status of the pandemic in the local community.
You're still muted, Derrick.
My apologies. Thank you for the introduction, Doctor. I appreciate it. My name is Derrick Neal. I'm the Chief Public Health Officer for the City of Cambridge. So looking forward to sharing with you tonight. I've learned a lot already from the physicians. So looking forward to your questions. I think I better get the acknowledgements out of the way at the beginning. And so I certainly want to thank our dedicated staff. We have approximately 55 staff people who operate a nationally accredited health department. So I really want to thank them for all of the work they've done throughout the course of the pandemic. It has not been an easy path for public health, but really listening to the research, the development, the things that are going on with the vaccines and those studies, it's extremely helpful. Throughout this pandemic, we've been focused on science and talking about believing in the science. And we truly believe in the science. So it's really great to get that baseline as we go into this presentation. We can go to the first slide, please. So I just wanted to bring your attention to what's going on in Middlesex County and not necessarily specifically Cambridge, because from a public health perspective, we always have to look at what we do from a regional perspective and not just operate within the confines of Cambridge, because we share community, we share borders. So it's really important that we look at these things from a public health perspective. So I want to thank everyone for joining us this evening. I'm going to be providing some Cambridge specific information for you to give you a sense of where we are as a community at this point in time. This slide shows that the COVID-19 rates in Middlesex County, which are the bars, and in Cambridge, which are the small dots, the solid black lines on the 7-day chart, show the 7-day reflect the 7-day average of new cases per 100,000 people. The chart also shows the CDC's 4 levels of transmission risk. The smudge of blue you see on the bottom of the chart was last summer before the Delta hit, when the infection rates in Cambridge and the county were relatively low. And we all remember that was after the wave of the first vaccines, or the second vaccines came out, and it was a real big push to get individuals vaccinated. The problem with that is we never reached herd immunity from a vaccination perspective. So we never had enough people in our community or in this country that were vaccinated. And that's one of the things that we're continuing to deal with now. So I just wanted to share that with you. Since mid to late July, when the Delta wave began, both Cambridge and Middlesex County have been in the CDC substantial transmission risk categories. And that's important to note. The other thing that I want to mention to the group that's incredibly important, and we're going to talk about this in some of the later slides, is that yes, we're currently still in the pandemic phase, but we are seeing some indicators and some signs that this disease may be endemic at some point, which means it may be with us, maybe here to stay, much like the seasonal flu that we deal with, our influenza that we deal with on a day-to-day, on an annual basis. The current Omicron wave infections peaked in Cambridge and the state on January 8th and based on the 7-day average of new infections per 100,000 people. Since that time, we've been falling drastically in terms of the leveling off of infections that we have. But what I want to, the analogy that we've been using and is spreading pretty fast is that even though we're dropping at a significant rate, we're still at a relatively high rate of spread going on in our community. So it's important to keep that in mind, that we were so high. It is important that we take some level of comfort that the numbers are dropping, but we're not out of the woods yet. And I want to make sure that I'm bringing that point home to each of you who are within listening distance of my voice. Clearly, we are in a much better place than we were 2 weeks ago, but we're not out of the woods yet. Next slide, please. The Massachusetts COVID-19 hospitalizations, that's always incredibly important that we look at hospitalizations, because capacity within the hospital systems are incredibly important to us, because if we don't have enough healthcare workers to care for those individuals with just the normal conditions that people deal with when going to the hospital or the emergency room, we certainly wouldn't have the capacity to deal with an influx of individuals who are dealing with COVID-19. And if we don't have anyone to care for them, then we start making decisions such as prioritizing care, who receives care. So the hospitalizations are an extremely important indicator, because it tells us where we're at with regards to capacity, as well as the impact that the Omicron variant is having on our community. So those things are incredibly important that we focus on. About 2,000 Massachusetts residents are currently hospitalized with COVID-19. So in my mind, that's pretty significant. This is lower than 2 weeks ago, which marked the peak of Omicron hospitalizations in the state of Massachusetts. But as you can see on the graph, COVID-19 hospitalizations are still higher than at any other point in the pandemic during the initial wave of the infections in the spring of 2020. So we've had more cases than we've had at any point during the pandemic. That's important to note, because a lot of us took a lot of comfort in the fact that the numbers dropped precipitously, but we're still dealing with a virus that's finding a way to mutate and reinvent itself, so it can continue to harass us and impact our lives in a negative way. So we haven't, we used to talk about bending the curve. We don't see any curves in terms of the growth. We just see spikes in terms of cases. Omicron appears to cause less severe illness in on the population than the previous variants, but the hospitalizations reach record highs because the virus is more transmissible, and that's just the reality of what we're dealing with at this time. It's more transmissible. There are almost 500,000 new infections statewide between December 1st and January 30th. That's extreme. That's significant. We're going to touch a little bit about the deaths as well, because initially, we were thinking that it was less deaths associated with Omicron, but we're still seeing that number steadily creep up. And again, deaths are the last lagging indicator. We don't hear about deaths sometimes until weeks or months down the road, because of a confirmatory processes that our medical officials have to go through to ensure that COVID-19 was the actual cause of death. And we don't want to guesstimate that, because we want to have an accurate picture of what this virus is actually, the havoc that this virus is wreaking on our community. So that piece of it is incredibly important to note as well. And I do apologize, but I'm having a little difficulty in looking at my notes, but please be patient with me. I believe I'm the last presenter, so try not to make this too painful. Next slide, please. We want to talk about ongoing mitigation strategies. We continue to stress the tried and true public health measures that we know are effective in stopping the spread of the virus, the harm caused by the COVID-19 vaccines. COVID-19 vaccines and boosters are high quality mass testing and physical distancing. we've never backed off the mitigation practices that we've focused on the entire 2 years that we've been in this pandemic. Those are the things that we know that can keep you safe. I had a discussion today with some colleagues in terms of the quality of masks. We talked about the KN95 mask and those various masks, as well as the cloth mask. But we have to understand that those mitigations, even the vaccines, aren't 100% effective, but collectively using all of those mitigation practices will give us the best chance to not only combat COVID-19, but to remain healthy and protect the ones that we love, and even that neighbor who we don't know, protecting them as well, because we all can be unknowing carriers we can unknowingly carry a vector that can harm someone, even though it may not be impacting us from a physical perspective. The city, the health department, and Cambridge Health Alliance are all hosting vaccine clinics. So we have vaccine availability throughout our community. We're going to begin passing out the rapid tests, the antigen tests, because the PCR test that a lot of you have engaged or taken that test, and that's the gold standard, that's the high quality test where they're sampling mucus in the nose. What we want to begin to do is really shift the testing responsibility to our citizens, because quite frankly, the pandemic is in the hands of our citizens. We know exactly what we have to do, the practices that we need to participate in order to stay safe. Some of us are making informed decisions, and I thank each of you for doing that. Some of us are making uninformed decisions, and it's keeping us in this posture, or what I would call a hamster wheel, of continually responding. Until such time we have enough individuals inoculated, vaccinated, we're going to continue to experience these spikes. So that's incredibly important to know, that the pandemic is in the hands of our citizens, our country, and not necessarily in the hands of public health, because we've communicated all the facts, the data to you. And again, we have to take control and take our lives back by making informed decisions. So those things are incredibly important. I want to make sure that I stress that. But again, enough vaccines are available. We just need folks to take advantage of those available resources that are in Cambridge or in other ancillary bordering communities. We continue to provide education about the importance of high quality masks. The city has purchased masks for distribution, and they'll be passing those out through the fire stations. That information should be on the City of Cambridge's website. Again, that's expected to begin next week. Given the high level of transmission of the virus, masks remain a very important in helping us control the virus. The city also remains committed to testing, offering free PCR testing daily and purchasing rapid tests for distribution. Our message to residents continues to be that they should test if they have symptoms or have been exposed to someone who has COVID-19. Next slide, please. I want to speak a little bit about the COVID-19 case rate by neighborhood. And for those Cambridge residents, you can identify your neighborhood on this particular map to see where you're at. The map shows the COVID-19 case rate by neighborhood. The neighborhoods in darker red are those with the higher rates. The Port, Wellington, Harrington, and North Cambridge are our areas of greatest concern. We have observed inequities in risk for COVID-19 residents. We talked a little bit yesterday about the Fresh Pond and the housing complex in that community. And I wanted to really, take the time to go over and visit. And I was taken aback by the close quarters in which individuals have to live and pass by each other. And we've been doing some concentrated specific outreach with our neighborhood core groups to go out and provide health promotion. And health promotion is education, which is the most effective tool that we have in our toolkit. We can give out all the vaccines that we want. We can, offer these testing resources, but it's incredibly important that we educate our community on the importance of why vaccination programs are important, and not just why is the vaccine important, and the role that they can play. When we are able to offer health promotion, and if we are effective, we educate individuals, and that begins to break down barriers and generational curses and misinformation, which has been one of the drags on this entire pandemic, is the level of misinformation that is out there on social media, as well as being passed from individual to individual. You can get the facts from your local health department or from the CDC's website. But again, we have to ensure that we're communicating good, accurate information so individuals can be armed with that knowledge and make informed decisions. So that's incredibly important to us as well. I think that's all I have for that particular slide. We can go to the next one, please. Okay, the COVID-19 vaccination status of Cambridge residents by age. And we can see that our lowest vaccinated group obviously is going to be those children who are under, well, not children who are under 5 because they're not eligible, but children from 5 to 11 years old. We have within Cambridge some of the highest vaccination rates, not only in the state of Massachusetts, but we have some of the highest vaccination rates in this country. But still, it isn't good enough. It's going to take all of us to be participatory in this vaccination program, as well as a strong health promotion and mitigation program as well. Those things are incredibly important so we can make informed decisions. I do applaud the city of Cambridge, as well as the Cambridge Public Health Department. Long before my time, we did a tremendous job of protecting our most vulnerable citizens, our seniors, our homebound folks that we have in Cambridge, by providing vaccinations to that group. Hence the fully vaccinated number of 76%. That's unheard of, but we can still do better, because we still have individuals as recently as a week and a half ago that were passing away that were over the age of 80. So we have to make sure that we are taking even more steps to protect our most vulnerable citizens, as well we should. So I just wanted to mention that. Overall, 90% of residents have received their first dose and 75% are fully vaccinated. Those are good numbers, but we certainly can do better. A very high percentage of our population of age 50 and older are fully vaccinated, and booster rates are climbing to respectable numbers among this group. Our vaccination rate for children 5 to 11 years old is also increasing. This group is not yet eligible for boosters, having just been approved for vaccinations in November. So we still have a ways to go with that population. We will be doing more to promote boosters for the 12 to 15, the 30 to 49-year-olds, and second dose boosters for those 16 to 29 years old. Next slide, please. If we look at COVID vaccination status, the big word that we're using in public health in phrases is health equity and also social determinants of health, which simply means that where you live, work, and play not only determines your quality of life, but it determines your life expectancy. A lot of that has to do with the resources that you have available within your respective communities. So I just wanted to highlight the the vaccination rates among Asian, Blacks, Hispanics, multiracial, and as well as our white citizens. Those things are incredibly important because a lot of this has to do with, we talk about generational curses a lot and trusting the healthcare system. A lot of that has been our challenge throughout this pandemic. With the quick onboarding of vaccines, it was a lot of mistrust that was there. So a lot of education had to be done and a lot of outreach had to be done. One of the things that we did in Texas was that as an African-American public health director, was that we wanted to go on camera. I was on camera receiving my first vaccine because what we want to do is really demonstrate to our community that the vaccines are safe and their efficacy is tremendous. They've done a lot, not only to protect us from illness, but to preserve life. And that's the most important thing when we talk about public health. We want to make sure that we're making the best decisions for the collective of our community and not just for a single individual. Overall, we have high vaccine rates. Our percentage of Black residents who are vaccinated, for example, exceeds that of the state. But again, the data also is pointing to some areas that need more attention. We're looking at the booster numbers for our Black and Hispanic residents, which are lower than we would have expected given the uptake of the first and second doses. So while those populations, specifically Black and Hispanic individuals, to a degree lend themselves to getting those first two vaccines, we're lacking when it comes to getting that third booster. And that third booster is really, really critical in terms of being able to push through this current surge. So that's going to be incredibly important as we move forward with that knowledge. Next slide, please. So we talk about the post-surge, and at the beginning of the discussion, I mentioned about the pandemic going from a pandemic to being endemic, COVID-19 being much like influenza, or how we treat the seasonal flu. So I wanted to, we need to begin to have that conversation because we can't continue to approach this pandemic the way we have been doing. But again, as I stated earlier, it's too early to discontinue measures that we put in place to fight Omicron. Cases and hospitalizations, while declining, are still higher than at any time in the past 12 months. So that's really, really important to note that even though we're seeing the decline, we've been here before. We've seen the decline when we onboarded the vaccines, only to experience another surge. So we've been here before. We know that we can't get too excited. But again, we are enjoying the good news. But again, we're certainly not out of the woods yet. So we're still in the pandemic. And I don't want to leave anyone with the message that it's okay to let your guard down, because it's absolutely not. We're too close to the finish line to give up, quite frankly. We have been living with COVID-19 for over 2 years, and it has been a chaotic and stressful time. And as I was speaking with someone earlier today, pandemic fatigue is real. Not only do we work, we managing the pandemic response along with the city of Cambridge and a lot of other partners. Have a great fire and police department here. We still have to come home and manage COVID fatigue and deal with the effects of COVID in our own homes. So we understand what you're dealing with because we deal with it as well. But we can't let that fatigue become, we can't be complacent when it comes to combating COVID. We can't let our guard down because it's incredibly important. And remember, oftentimes we have the health and the wealth, because health is wealth, of our neighbor in our hands based on what we expose them to and what they could potentially expose us to. While we can't change the fact that the virus is still spreading in the community and that there are more transmissible Omicron variant headed our way. I'm sorry. I lost that point, but essentially what we don't want to do is that we don't want to give up. We're too close to give up. We are all tired. We are all worn down by COVID-19, but we still have to keep moving the needle as far as we can in order to make it through this. You know, my hope is that I can go out with my family and have a great Valentine's Day dinner in a safe manner and safe socially distance and using all those mitigations, because we certainly deserve it. And I think we're at the last slide. I just want to thank my staff for all the work that they've done. When you see a healthcare worker, a public health worker, a firefighter, a police in the city of Cambridge, or just a municipal worker, they've all done their part in combating this deadly virus in our community. Thank you for your time, and thank you for taking the initiative to sit with us this evening and learn more. It's incredibly important that you all serve as public health ambassadors by going out and educating a neighbor so we can get past this pandemic. Thank you very much.
Thank you very much, Derrick. Thank you, Wilfredo. Thank you, Gaurav, for all this information. I feel like I've learned so much. Thank you to everyone who submitted questions via the chat and the Q&A. And there was one more question that came in with regards to the slides that were shared. I know this conversation is recorded, but if folks are interested in seeing the slides, Gaurav and Wilfredo, is there somewhere that those are accessible, or should they reach out to you directly in order to have them emailed?
Happy to respond to anyone and provide slides, and happy to provide them to the public library at a central location for people to access as well.
Gaurav, if you'd like, I can coordinate that. That's fine.
Sounds great, Don.
Awesome, great, thank you. Now, in interest of time, we would like to, end tonight's program and thank everyone again for coming and learning about the new ways that we can remain safe and vigilant, as Derrick mentioned, for us to continue our fight against the pandemic and hopefully ending or, getting on the other side of things. So this video will be made available to the Cambridge Health Alliance, and we'll figure out with the library where we can host this so that we can continue to have those conversations. And again, I would like to thank everyone who's been behind the scenes coordinating this, Jose, Dawn as well, for all your support. And thank you, everyone. And we hope that everyone has a safe and wonderful evening. Have a good one, y'all.
No, I'm on.